Okay, hello everyone, good afternoon, and welcome to the Clinical Trials Methodology course webinar series. My name is Michelle, and I'm an administrative assistant helping with the course today, and I'm glad that you could join us. Before we get to the presentation, I want to remind you of a few things. If you have questions or comments, please use the chat box or the Q&A features at the bottom of your screen. Also, please complete the evaluation for today's webinar so that we can improve future webinars. The link should be in the chat box. And lastly, our next webinar will be on optimizing clinical trial design in rare disease, presented by Dr. Melanie Quintana. Today's webinar is on ethical issues in acute and chronic neurological conditions and presented by Dr. Michael Link. Dr. Link is the chair of the University of Cincinnati IRB and the StrokeNet Central IRB. He obtained a doctorate in pathology from the University of Cincinnati in 1993 and completed a postdoctoral fellowship at Cincinnati Children's Hospital Research Foundation in pulmonary biology in 1995. He retired as a health science officer from the Cincinnati VA Medical Center after over 30 years of service in 2018, where he studied pneumocystis pneumonia. He is currently an adjunct professor of internal medicine at the UC College of Medicine and has served as chair of the UC IRB since 2004. He led the formation of the StrokeNet Central IRB in 2014, and the NIH created StrokeNet to conduct clinical trials to advance acute stroke treatment, stroke prevention, and recovery. This network of 25 regional centers includes more than 300 research sites. I want to thank Dr. Link for his time and presentation today.
Thanks, Michelle. Hi, everybody. So I'm going to talk today about some ethical issues, kind of focused on neurological conditions, but starting off just in general, reviewing some of the basic ethical principles. I think it's always good for IRB chairs in their presentations to start with that, to remind everybody of what we need to do to conduct ethical research and what regulations and principles we need to follow. And then I recently had a discussion with one of our investigators here at the University of Cincinnati about a study he wanted to do related to deep brain stimulation. So I thought it might be interesting to discuss, how you run those types of trials and how you deal with post-trial access to implanted neural devices. Hopefully we can get some discussion going on that. And then if we still have time, one of my areas of real interest is the exception from informed consent research, which it is also at the University of Michigan with Dr. Silbergleit's leading role in ethics studies and providing guidance on those. So we recently had a study where where the investigators wanted to enroll conscious patients, which really doesn't fit with the usual profile of ethics studies where patients are usually unconscious. So could discuss the issues that came up with trying to enroll that patient population. And as always, feel free to jump in if you have questions about anything else. If you want to talk about something else, I'm happy to talk about something else too. So this is just a basis for us to start. So a few years ago, American Association of Neurology updated their ethical statement. So we can go over that. And really, it's based on this paper from Dr. Ezekiel Emanuel. They used their 7 principles. They adapted them a little bit for related to neurology, but really their principles are based on this paper from Dr. Emanuel. So they talk about the 7 principles, and these are also reflected in documents like the Nuremberg Code, and we're going to talk a little about the Belmont report, and then also the Declaration of Helsinki. But these are the principles put forth in those 2 papers. So social value, there needs to be a real good scientific merit to these studies. You can't just do studies for the sake of research and putting human subjects at risk without having a good basis for why you want to do that study. And again, there needs to be a good scientific process to these studies, good methodology. A lot of times we get pushback at the IRB when we bring those issues up about study design, but it is something, you know, study needs to be well designed in order to benefit either the individual or society. Fair participant selection. There needs to be a good reason why you're including a certain population or excluding a certain population. The excluding has gotten more attention lately in terms of excluding certain populations such as pregnant women for studies with no good scientific basis for that. We're going to mention that later too when we talk about the Belmont report. And of course, the studies need to have a favorable risk-benefit ratio. You know, in general, there needs to be there needs to be benefit to these studies that involve risk. Of course, sometimes there isn't. Sometimes there is no direct benefit to patients or participants in the study, but there is more than minimal risk in the study. And in those cases, the studies really have to have a very sound potential benefit to society or the patient population if they don't have a direct benefit to the participant in the study. You know, if you get into studies that involve no more than minimal risk, then the benefit question probably becomes a little less important, but it's still, you know, I always get a little upset when I get protocols from investigators, even if they're just things like chart reviews, and they say there are no risks in the study. And really, there's always some risk, at least a risk of loss of confidentiality. So even for minimal risk studies, there should be a good benefit to the study, either in general or to the individual patients, participants. And then studies need an independent review, and that's why we have IRBs in the US, and we have ethics committees in Europe and other types of boards in other parts of the world. But they need an independent review, and the IRB is truly an independent body. If an IRB at an institution disapproves a study, that study cannot be done at that institution. You can't go shop it to another IRB to try to find approval. So, you know, IRBs definitely provide an independent and hopefully expert review of these studies. If the IRB, if a specific IRB doesn't have the expertise, we can always go to an ad hoc review. I just did that on a study recently. So it's really important to have a good independent review of these studies. And then, of course, informed consent, the cornerstone of ethical research. And it needs to be a complete, understandable consent form. Some of the changes to the common rule address this, with now requiring inclusion of the key information section, a short beginning that really tells participants whether or not they even want to consider, provides them with information to determine whether or not they even want to be in a study. So, and then the revised common rule also requires basically that consent forms need to be understandable. It's probably more of an issue in FDA regulated research. And just a couple of weeks ago, the FDA released their proposed changes to their regulations to harmonize with the common rule. And then their regulations, if they're accepted as is, following the process, the institutions can provide comments, so they'll do that review. But if they stand as is, FDA consent forms would have to be understandable. And hopefully we can use that to get the pharma sponsors of these trials to stop using these 20 or 30-page consent forms. So they need to be understandable. They need to provide the important information participants need, and in an organized fashion. And then there needs to be respect, you know, and this is reflected in some of the other principles also. You really, and this goes into more of probably a subjective determination, you know, what is respect? But, you know, you need to basically treat the participants as you would want to be treated, as your mother, you want your mother or your father treated, as we always get those questions. So really the respect for the participants and making sure that they're treated as autonomous individuals, and they're able to make their own decisions, and they're given enough information to make those decisions. And then there's the Belmont report, which I'm sure you all heard of. So we'll just do a brief review of the ethical principles of the Belmont report. And the Belmont report was in response to the discovery of the unethical human subjects research that was being done in the United States with federal funding, and mainly the Tuskegee study, the syphilis public health service syphilis study in Tuskegee, but there were others too. But that was when the commission was put together to consider how human subjects research should be done in the United States, at least. So they came up with three basic principles. And the first one is respect for persons, which we previously saw in the AAN principles. And in terms of the Belmont report, we're really talking about making sure that people have a voluntary consent to participate. There must be an informed consent. Of course, with that said, as we're going to talk about later, there is now a mechanism in the federal regulations. FDA, HHS also allows this type of emergency research with an exception from informed consent. And that, that regulation wasn't around when the Belmont report was first put out. The principle of respect also relates to the importance of protecting the privacy and confidentiality of participants. Privacy and confidentiality, investigators often mix up the privacy and confidentiality requirements. So privacy is, for an example, making sure that the consent process is being done in a private environment, and people are allowed to make that decision on their own. I recently reviewed a study where they were going to do a group informed consent process, and it was a fairly risky study. It wasn't a clinical trial, but that's not really an informed consent if you're going to have everybody do that as one. Consents need to be done in a private place, and then confidentiality is probably better understood, and that's protecting the data and making sure that you're storing it in a secure way and transmitting in a secure way, and using de-identified data whenever possible. So something to remember, the difference between privacy and confidentiality. And then participants always have a right to withdraw. That's something that's essential to ethical research. And we still get that question sometimes, can I stop the study? And yes, anytime you want, you can stop the study. FDA regulated research, there is a requirement that if you withdraw, the data that was previously collected still can be used. Other studies, it may not be, depending on the protocol and what's stated in the consent form. Sometimes there may be recommendations for some follow-up because you're in the study, but participants always have to have the right to withdraw. And then there's beneficence, and beneficence really is an obligation of researchers to do no harm and to provide, and that there is a good benefit to these studies, and make sure they're treating these treating participants with the potential for harm. If there is harm, making sure they have procedures in place to manage that, and that really it gets into the principle of beneficence is related to maximizing benefits and minimizing harms. And IRB spends a lot of time looking at the risk-benefit ratio of these studies, as I discussed previously. And then justice. Justice is looking at the distribution of risks, and it really came out of studies that were targeting certain populations just because they were easily accessible, with no scientific justification for including those populations. So research should enroll patients or participants based on scientific reasons of why they should be included in that study, not just populations because they're easily to manipulate. An example of this is studies that were done on prisoners. Just because prisoners were easily accessible, there was no reason that prisoners needed to be targeted in those studies. So you really need to make sure that there's a good rationale for why patients are being included or excluded from studies. We also mentioned that while talking about the AAN principles. And then, as I talked a little bit before, there is this debate, recent debate now, over whether the principle of justice always also applies to not excluding people from studies for no good reason. And really that discussion is focused on pregnant women related to some of the COVID vaccine studies, and they weren't included in the studies. And then how do you make decisions about whether or not to recommend the vaccine to that patient population? So that's something we're looking at now. We had a protocol just last week where they said they were going to exclude pregnant women, and there was no real justification of why. There didn't appear to be an increased risk. So we asked that question now, at least, and so at least people are thinking about it. We don't talk a lot about the Declaration of Helsinki in the U.S., although some FDA-regulated pharma studies do follow the Declaration of Helsinki. It's out of the World Medical Association, and it's really directed towards physicians, which is a little different than the Belmont report, but it is a very detailed document. It talks about specific issues much more than the Belmont report does. So it is something to remember, and I mention it now because it'll come up later when we're talking about the neural device implantation studies. Anybody have any questions or want to talk about something else?
I mean, no, this is quite good. I think, I've got some things that we can bring up after you kind of get through your set things, but I think
okay.
This is great.
Okay, thanks, Will. So as I mentioned before, talking about these implanted neural device studies, and you guys are all familiar with these, most of the research and papers that have been done on the ethics of this are related to the deep brain devices, the implantable devices, usually approved for several things, but I always think about Parkinson's when thinking about the DBS. But then there's all these other kinds too. So when you're doing these studies, there's lots of issues that come up, and there's many good papers on considering those issues. In addition to what happens after the study. There are other concerns with conducting these types of studies, but today I was going to focus on this idea of what happens to the devices when the study's over. I had an investigator approach me, it's been a couple of years ago now, and he was considering doing a study using deep brain stimulation to improve gait in stroke patients. He had done some research and looking at the Parkinson's disease therapy, he felt that this could potentially benefit the stroke patients. He was working on it, but then there were concerns raised about what happens after the study's over, and what if participants in the study were benefiting, and then you had to remove it. And then if you didn't remove it, who's going to cover the cost? Who's going to maintain it? Who's going to follow up on these patients? So he got kind of hung up in that issue. There were some other issues that happened that you see that also affected whether or not the study could be done here. But at that point, it was never initiated. And I looked, and I didn't see any studies that have been done in the stroke patient population with DBS. I don't know if you guys know any, but it looks like it's still a question that could be asked. So a recent paper that came out looked at this post-trial access and implanted neural device research, device maintenance, abandonment, and cost. There's a number of other papers out there, but this one interviewed researchers and patients or participants in these studies to get their impression about how they felt about the access after the trial to the devices. So the issue is, that you're doing a study, you're using one of these implanted devices, and the study's over, and some people in the study benefited, whatever benefit means, and now what do? Hopefully you considered that before you started the study, or at least the IRB made you consider that before you study. But that's the background in terms of this discussion. So, one question is, do participants have a right to continued access? Anyone have any thoughts on that? So, looking at the ethical principles, perhaps the AAN position statement, respect for participants, the idea that you're going to take something away that they were benefiting would indicate that, yes, participants should have a right to continued access of these devices. Belmont report, probably the principle of beneficence, making sure you're maximizing the benefit to these patients or participants. And then this is why I brought up the Declaration of Helsinki earlier, which I don't normally discuss, but one of their principles does specifically address this issue. And that's what I was saying. The Declaration of Helsinki contains much more detailed information. And so they actually say, investigators should make provisions for post-trial access for participants who still need an intervention and they receive benefit from the study. And it should be disclosed during the informed consent process. There's much more experience in this in terms of drugs versus devices, and better guidance on how to manage it in drugs. And it doesn't raise the same issues as this implantable device study, but the Declaration of Helsinki specifically requires that there is a plan. And then when they talk to the participants in that study, most participants felt that they should be able to keep the device. And in some cases, they just expected they were going to be able to continue the device, that they were going to be able to keep the device, but without really understanding the information that was provided in the informed consent. Some barriers to continued access. The cost, obviously, there's the cost of maintenance. These devices usually involve some sort of battery. Battery replacement can be very expensive. Sometimes there's regulatory restrictions. So if the devices are not FDA approved, how do you continue to use that once the study's over? And then if they're not FDA approved and they're only being done in a research study, there's probably limited access to people who actually have expertise in dealing with these devices. So who's going to continue to see these patients, and whether or not the investigator is able to do that is something that needs to be considered when you're designing these types of studies. So the responsibility of researchers, I don't know how realistic these things are. I'm not a physician, but the one idea was that they could charge the specialized visit as regular visits. That didn't seem like it would work to me, but it was discussed in the paper, and it would be a way of reducing costs to participants. I guess hoping then that insurance would cover it, which is an issue on these things. And then speaking of insurance, dealing upfront with facilitating insurance coverage. So not waiting until the device is already implanted, but during the study design, facilitating the potential insurance coverage, at least understanding what might potentially be covered or not be covered. And that should be a responsibility of an investigator. And then it was interesting, and I never thought of this, but they talked about choosing sponsors that offer follow-up care. And there was one investigator they talked to that said he's always done these studies. I don't know how many he has done, probably not a whole lot, but he said when he's done them at VAs, because the VAs do cover those types of costs in the research study for the veterans, which is so running trials at the VA. There was a suggestion that you could also, you get your money to do the study, and then potentially there's some type of mechanism for applying for follow-up grants to continue to receive funds to cover the continued access of these studies. I think, I don't know how that would work practically. You already got the study up and going, then you're going to try to apply for grants. we all know how well applying for grants usually goes. So I'm not sure. And, that's another point that points to making sure there's a plan in the protocol on how this is going to be happening, and not waiting to deal with this after the study is already up and going. And then there's the consent process. What should potential participants be told? And in the responses from some of the participants in that paper, they don't remember, they didn't understand what they were being told. They thought they would continue to get the device, to be able to keep the device, but that wasn't necessarily allowed by the study. So really discussing the long-term implications of what's going to happen when the study's over. And as I said, and I think that's in general in consent, not just related to this continued access, but in papers that have been done reviewing participants' understanding of the consent process. They don't often retain a lot of the information that was provided. Hopefully, in simpler consent forms is going to improve that, and then also providing the consent form to participants so they can go back and reference it helps with maintaining the information that was provided during the consent process. And then there's this whole other issue of therapeutic misconception, which is a problem in research and human subjects research in general. So in the consent form, if you tell them they're going to be able to keep this device after the study's over, they may think, well, then the device is going to work. Even if you tell them it's only if you benefit, we don't know if it's going to work, but people grasp certain things during the consent. And, if these people are desperate in terms of finding some treatment, they're going to think, well, if I get to keep this device is going to work. And so that, that therapeutic misconception issue gets a lot of discussion in the IRB, ethics IRB world. So you have to be careful how it's presented to participants. And then, who gets to keep it? And that goes back to therapeutic misconception in discussion as related to informed consent information. So those that benefit, but what is benefit? Yeah, that in the study, it's probably actually defined in terms of the specific aims and what the study would consider benefit. But at what level is that a real benefit, a real clinical improvement to participants? So how do you make that decision who would be able to keep the device? And then how do you explain that to participants during the informed consent process? And then there's, the big issue beyond just the ethics of allowing people to keep something that's helping them is the cost. And you guys all know that the cost of these is very expensive, and who's gonna cover that cost. There's some discussion that the device manufacturer should cover this cost, especially if it's a new device that's being treated in a study and you get positive results from the study. So they're gonna probably be able to get FDA approval for this device and make lots of money. And then so maybe they should be responsible for covering the cost of the post-trial access for patients that were in the trial that led to the FDA approval. Insurance, that's difficult nut to crack in terms of getting insurance to pay for things. So, if it's FDA approved, that might make it more insurance companies more receptive to covering these costs. There was some discussion in the paper, and some of the participants actually felt that they thought participants should cover the cost. I'm not sure they were aware of the amount of the potential cost of these studies, these devices, when they said that, but there was some discussion that participants could cover the costs. And, if that was clearly defined and described in the consent form, that's a potential option. And then the research team. So should there be a mechanism as part of the protocol to cover the continued access to these studies? And that's where our investigator at UC kind of decided that he didn't have any way to do that. Even if he could get the study, it was probably going to be an investigator-initiated study without any federal support or pharma support, at least at the beginning. So he really wouldn't have the mechanism to cover the ongoing costs. So those are the general issues. I don't know if any of you work in this area and have thought about this before, but I think it's an interesting situation, and we'll probably see more of these types of studies. And hopefully this provides some guidance if you end up going down that path. And then I was going to talk a little bit about EFIC research. I would imagine you're familiar with EFIC research, and it's allowed under the FDA regulations 21 CFR 50.24, very detailed regulations on how these studies need to be done. And then the HHS also allows these studies based on a letter from OPRR, which is now OHRP, saying that these studies can be done according to the FDA regulation 50.24. So sometimes you get studies that are funded through the NIH, but are also regulated by FDA. So these are the basic conditions. It has to be a life-threatening situation that requires urgent intervention. There has to be no proven treatments available for the condition you're studying, and it's necessary to collect new scientific evidence to show the effectiveness of the new intervention. And informed consent is not feasible, and this is one of the requirements that gets a lot of discussion and what we're going to talk about later. And that there's some emergent reason for administering whatever the intervention is before consent is obtained. So the regulations talk about defining the therapeutic window for these studies. So what's the time where, in order to get the most gain out of the intervention, it needs to be administered? And there's no prospective way of identifying potential participants, so you can't say that this group of patients is more likely to be in these studies. That's one of the requirements. And there has to be a direct benefit in these studies to the individuals in the studies. So this is a little different on other studies where there can be no direct benefit. But in EFIC studies, there should be direct benefit to the participant, potential direct benefit to the participants. And then it could not be carried out without the waiver. So what I was going to talk about today related to EFIC is, now there weren't a lot of EFIC studies being done. One of the first ones that was done was the blood substitute study, and it didn't go very well. There were problems, bad press. But since then, there's been a number of really successful EFIC studies, and some of those done out of the University of Michigan. And one of the examples is the Rampart study on seizures, and it really was a well done study that provided good clinical evidence from the study. So we're seeing more of these being done. There's the commercial IRBs now are reviewing some of these, and so there's a real increase in the number of EFIC studies. And one of the issues that's coming up as we see more of these EFIC studies coming online is patients that could potentially qualify for these studies that are conscious, and maybe they can't understand a full consent process, but they could say yes or no in terms of being in the study and how you fit those patients into an EFIC study based on the regulations. And so there's good FDA guidance on EFIC studies. They have a really thorough guidance document. So one of the questions in that, one of the FAQs in that is it possible to, for a patient who would be eligible for an EFIC study to actually indicate that he or she does not want to participate? So many times patients that are eligible for these studies are unconscious or they can't communicate for some reason, but the guidance does talk about other patient populations that could be conscious and could communicate. They they may not have the capacity to understand a full and informed consent, but they are able to indicate that whether or not they want to be in a study or not in a study. So this is kind of the group we're talking about now, and how we fit that group into EFIC studies, and how we fit them into the requirements for surrogate consent from LARs, or permission from next of kin to be in these studies. And then if the patient is able to understand a simple explanation of the study, if they say no, they shouldn't be in the study. So in the study that I was working on, there was a really short therapeutic window. They provided scientific evidence for a 5-minute window. So that's the amount of time from when someone is determined to be eligible to be in the study to the time when the investigational agent needs to be administered to be able to get the most benefit from that drug. So that it's really a short window. Sometimes these windows are longer, sometimes they're 30 minutes or an hour. But in this case, this short window also impacts how the regulations affect this study design. So in this case, eligible patients, they'll be conscious. And I'm not giving you all the details of this because it is currently being reviewed by the FDA, so I'm being a little vague in some of these descriptions. But they're able to communicate, and they do have compromised capacity to make an informed decision. But it was determined that they should be able to at least understand a basic description of the study. And that they would be able to indicate that they don't want to be in the study. And in this case, the sponsors decided that if the patient declines to participate, his or her wishes will be honored in keeping with the FDA regulations. But then they also decided that if a patient is unable to understand the simple description, the patient will not be enrolled. So they did develop an opt-out script. This was developed by based on a paper that Neil Dickert published a few years ago on this patient population. And so if this is an interesting piece of this study design. Someone has a question?
Yeah, so I guess because the patient population requires some consciousness, so it's not like a situation where a proxy could consent.
Yeah, that's one of the big questions when we start to try to fit this into the regulations. If the patient is able to make this decision, how does the proxy or surrogate consent come into play? And then the other issue with this study is that short therapeutic window. So we'll talk a little bit about that, Will, related to that question. So the process is the eligible patients will be given this short description. It's a formal short paragraph that describes the basic study design and the basic risks and benefit to a participant. And then the regulations require that there's procedures in place to protect the rights and welfare of subjects, and there's specific procedures that need to be in place, but then there's also more of a vague requirement that anything else that can be done to protect the rights and welfare of subjects should be done. So in this study, they incorporated this as an additional protection, and I think one of the important things is that if they don't understand, they're not going to be enrolled. So that leads to some of the problems with fitting this study in under the regulations, which is related to the question Will brought up. So there's this A5 and A7 sections of 50.24, and that state the investigator has to commit to contacting an LAR and asking that LAR for consent. There is some wiggle room in there because they also talk about if feasible. But it does say that you have to commit to attempting to contact an LAR. And then under the additional protection section of the regulation, they talk about if you can't contact an LAR, you have to commit to contacting a family member that may not actually be an LAR, which we could have a whole separate discussion on making that distinction, but this is the other requirement to ask whether or not that family member objects to the subject's participation in the clinical investigation. So both of these requirements really raise issues when you're trying to enroll this conscious population that's able to make their own, potentially make their own decision. And so in response to A5, we said that the narrow therapeutic window, and then in conjunction with the narrow therapeutic window, the inability to patients to provide informed consent, and that an LAR is not going to be reasonably available. This is a pre-hospital setting study. So we basically said that it's not going to be feasible to obtain informed consent for these patients. And the study and the regulations do talk about if feasible. So that's how this response to this regulation was addressed in the study. And then a similar response for A7, which requires contacting family members. And then we also added that, you know, what potential benefit to patients would there be to contact a family member to see if they object to a patient's enrollment in the study, because the patient will already made that decision, you know, or if they weren't able to, they wouldn't be in the study. So if a patient already said no, or patient said yes, it's really an opt-out. But you know, what would benefit would it add to contacting a family member? So, and this one also includes if feasible. So we use that to say, you know, that it really wasn't feasible. We did tell them that, you know, if there was a family member there, we would include them in the opt-out discussion with the patient. But the FDA didn't like these responses. They basically understand that it's really not practical to conduct either one of those, either trying to get consent from the next of kin or from an LAR, or contacting a next of kin because of the short therapeutic window. But they still required that we include in the protocol that they were going to attempt to contact an LAR to obtain consent, even though they agreed that it wasn't going to happen. And then same thing with A7. They want the protocol to state that you will commit to reach out to a family member, even though the odds of it happening are extremely low, and even if it's possible. So those are the kind of issues I think that come up when you're trying to enroll this patient population. We'll see what happens. You know, the FDA tells you to do something, you basically do it. I know other issues that have come up with a similar population where one of the requirements of 50.24 is that you have a prospective informed consent approved, and even though it's never going to be used, the FDA still wants you to provide that prospective informed consent. So as we see more of these studies and trying to work them around different nuances of research. Michelle, you have a question?
Hi, yes, Dr. Link. There's actually a question in the Q&A box from Simona, and they were wondering, how was this issue addressed at the initiation of DBS trials for PD? And I know this was asked a few slides back before the consent form. So
it was probably in respect to when they were first studying it, you know, in terms of how the device would be removed.
Yeah, you know, that's a great question. And I tried to look up that and I tried to find some of the old papers and I really couldn't. But yeah, that came up when I was discussing that with our investigator, that, yeah, they must have done this during the early trials for PD, but I couldn't find them. So that's a good point. And if anyone's ever going to go down this research path, it would be important to be able to find that, to see how it was handled for the early PD patients. And there's other approvals, right, for DBS that I saw. So
thank you.
So that's what I have. Anybody have thoughts about these topics or anything else? We've got time left. So.
Yeah, I mean, I guess, you know, it seems like is the it seems like in certain respects on some of these things, FDA has maybe become more conservative, maybe because of some public attention on and again, I mean, we're not going to have a political discussion here, but there has been some public attention on some acute care and critical care trials. So that may be something that is making things that 5 years ago FDA was more collaborative about and interested in sort of understanding that, we need to do this science to learn how to take care of patients with emergency conditions better, and which is often neurologic conditions because of the impaired cognition in those situations. But now it does seem like, some of the things that were a little easier a few years ago. I was involved in a submission of a mostly drug but partially device trial to be used in ambulances, and you may have even received some of the materials we used for that to sort of prepare for this submission that you've had recently. And they were, this was back around 2016, and they were relatively okay with our procedures, which were almost entirely what you just proposed, with the one sort of exception that because there was this emerging movement towards having physicians, stroke physicians and mobile stroke units, that we did have to build in provisions for if a study investigator actually happened to be present in the field when we were doing this ambulance study, we had to set up a procedure for, that they would use a slightly different procedure than the paramedics would, because they would be able to have potentially an informed consent discussion with a surrogate. But, the flip side of that is, assessing whether someone has residual capacity, assessing whether the surrogate has real standing, which varies by state, of course. Yeah. And with the clock ticking on the brain, so to speak, it's right. It's all a very, I think it's important that you're doing that work, but it's an area where I think hopefully, this submission and others over time will maybe lead to, reconsideration of the regulations, or whether there needs to be new legislation that allows us to do this in a way that's both ethical, but is, compliant, but also practical, so that investigators can actually answer these questions in honor of the biology. Right.
And I think some of the discrepancy is also between the different FDA divisions, or whatever we're going to call them, that some that may not be as experienced in the EThic world and maybe not as used to implementing them. So lack of consistency between those types of reviews is something I've heard discussed too.
I guess the other question, that is, in terms of this greater sort of right to try, which is sometimes some states have rules that regard that, which is sort of interesting because of, a lot of the things falling under FDA regulation nationally. And have you seen contrasts in sort of this movement of right to try experimental treatments? It seems like it's largely in the oncology space, or some rare progressive neurologic diseases, although less so. It seems like oftentimes it's in the oncology space in terms of, fifth or sixth line treatment, in which case it seems, it seems like a little bit less of a high stakes thing, as opposed to, perhaps, a drug for ALS that has, you don't have access to, but really seem to slow your progression. And then with the sort of third, the sort of third element of, devices are a completely different ball of wax in terms of trying, because there's just a lot more that goes into the maintenance, safety, and monitoring of something that's implanted. I guess what have you, in terms of the drug space, in terms of right to try, Have you seen that? Have you experienced that in the neurologic space in terms of, continued access to a drug from a trial, or perhaps, off-label access to an experimental agent in people with sort of dire situations? Have you seen much of that?
So the IRBs aren't seeing these right to try requests, obviously, which is not one of the issues, but it is just part of the legislation that it doesn't have to go to an IRB. But I still, and I still promote use of the expanded access regulations in the FDA as opposed to right to try. And as far as I know, right to try is not being used all that often. I don't think it's really caught on the way people thought it would. And the FDA does provide the expanded access pathway for access to experimental drugs, which works pretty well. And especially if institutions are used to dealing it, we get quite a few requests. Some of the requests are related to oncology, but actually, as I think about it now, most of the expanded access requests we've gotten recently are related to infectious diseases. We just got one for monkeypox. We've had some for drug-resistant TB. So we do get them, and we see some in the cancer field. I think, we don't review pediatric requests because Cincinnati Children's is right across the street, so they deal with those. I think they may get more of those requests for kids, but at least the expanded access, there's some oversight to this. The right to try is just really the Wild West, I think, in terms of getting access to these drugs. You got to find someone a physician who's willing to work with you, and so.
Yeah, although I think the COVID-19 pandemic has illustrated that there are physicians who will probably say
that's for sure
anything. Yeah. Although when I guess it comes to filling out a paperwork that has a lot of responsibilities and bad things that might happen to you with the FDA, people maybe don't have quite as much guts as they might when they're just talking on Twitter. I remember the other question I had, again, sort of going back to sometimes things have been getting a little harder with FDA. I think in your position as an IRB chair, sometimes we have this come up as we are studying a disease. Incidentally, some vulnerable population may have this disease, right? Like whether they're prisoners or whether they're pregnant women. We are not studying pregnant women per se. We're aiming to not systematically exclude them. But then sometimes the FDA and the IRB approval process sort of morphs into holding us to all of the conditions one would want to do. Like, let's say I'm studying a morning sickness drug, right? Where I am absolutely studying pregnancy. This is something that is really only targeted at pregnant women as opposed to some brain injury state where randomly some women might actually have that disease. How is the IRB and or the FDA, to your knowledge, set up to sort of handle those situations differently in terms of vulnerable populations? So the vulnerable populations that may be sort of caught in the net of the inclusion criteria as opposed to being the actual focus of the research.
Yeah, I think for more than minimal risk studies, you still have to then add the special protections for those vulnerable populations, which for prisoners and pregnant women can be a lot of hoops to jump through. I know there's some talk of potentially revising the pregnant women requirements because they're not necessarily needed to protect pregnant women and the unborn child. But right now, you see anyway, for studies that involve more than minimal risk, and they could potentially enroll those vulnerable populations, we're still requiring investigators to meet those additional protections for those populations. What we finally have stopped doing is for studies that involve no more than minimal risk, and you're not targeting those populations, then you don't have to meet the additional criteria for enrolling those participants. Years ago, we have a lot of, especially emergency medicine studies that are capturing all patients that come into the ER. And at UC, prisoners come into the ER all the time. And so if it's just during all the patients they're seeing, some of them might be prisoners, then we're not requiring those additional criteria for approval for including prisoners in research. But it is a problem, and I think there may be some movement, at least the pregnant women in that area, because there's a real push now to include pregnant women whenever possible.
Yeah, no, this had come up in an adult cardiac arrest study that I run, in that the new guidance from the FDA actually put, and feedback from our DSMB pushed us to actually, redact our exclusion for pregnancy from the study after it had been funded. And the FDA was supportive of it in that case in 2016. Because even though it was a more than minimal risk study, the reason it was really more of a comparative effectiveness study of different durations of cooling after cardiac arrest. So it was providing effectively, sort of guideline concordant care in some different ways. So it was a little bit of it's tricky, right? Like that, is that much more than risk than usual care? Anyway.
Yeah, I think that is their push now to include pregnant women whenever possible.
All right. Well, I think with this, I think we can wrap up now. I know that people probably have other things they need to jump onto, but Dr. Link, it is always a pleasure hearing from you. I know that we could probably talk all day about some of these issues in terms of this, and hopefully we'll get together soon at a clinical trials or research ethics conference.
That'd be fun.
Again, Michelle, is there anything else we need to do in closing? I don't think we do.
I don't think so. No.
All right.
Thank you, Dr. Link.
Thanks, Will. Thanks, Michelle.
All right. Talk to you all later.
Bye-bye.
Bye-bye.